Talk Podcast.
Welcome to the Pep Talk Podcast, where you can earn continued education anytime, anywhere. I'm your host, Michelle Andrews. Remember, if you want to learn continued education credit, you can purchase the course quiz from the show notes or the direct link I will share with the live audience. You must pass the quiz to download your certificate of completion that you can keep for your records. These hours are TISHA CEUs, and for ASHA, they count as professional development hours or PDH. We are going to learn about tongue tie releases and how to prevent them from failing, and how to know if you come across one that has already failed. My guest with me today is Autumn Henning. Hi there, Autumn.
Thanks for having me. It's one of my favorite topics.
Yes, I'm so excited to have you here. Let me tell everyone a little bit about you. Autumn is the founder of Chrysalis Orofacial and is a distinguished speech-language pathologist, certified orofacial myologist, and international board-certified lactation consultant with a master's in communication disorders from the University of Kentucky. She is the creator of the Tots and Stones courses and has her private practice in Greenville, South Carolina. Before we start the course content, walk with me through our virtual exhibit hall and take a look at this episode's sponsor, SpotPal.
Your tongue should rest in a nice suction to the roof of your mouth to eliminate any type of tongue thrusting habit or to eliminate any type of sucking habit. SpotPal is a custom fit tongue training appliance. It is designed to teach proper tongue posture and get the tongue to fit up within the confines of the palate where your tongue should naturally rest.
SpeechPal is our speech therapy version that is designed with the additional feature of the speech bumps on the inside of the upper molars, and these give tactile cues for the user, especially for the R sound. So with the spot dot and the speech bumps, we can target the S, Z, L, R, SH, CH, the J, the J, the T, D, and N sounds with tactile cues for the tongue.
Pretty cool. Autumn and I were just saying, I didn't know that SpotPal also had the little tactile cues for the sounds. Pretty cool. And they all have the spot to place your tongue for tongue placement. Very cool.
Yep.
I am so excited to dig into this episode content, but before I do, I will go over the course formalities for the course. Autumn's financial disclosures. She is the owner of Chrysalis Orofacial and is the creator of the Tots and Stones courses. Autumn is an affiliate to products that could be mentioned. Autumn's non-financial disclosures. She is currently appointed and in good standing as an assistant professor within the voluntary faculty series and the Department of Communication Sciences and Disorders at the University of Kentucky College of Health Sciences, and was a founding board member of the International Consortium of Oral Ankylophrenula Professionals. Yes, I practiced saying that.
I was gonna say.
That was a tongue twister. Okay, my financial disclosures. I have a Teachers Pay Teachers and Boom Learning store under Pep Talk. I'm the founder and manager of the Pep Talk Podcast. My non-financial disclosures include Speech Arcade is an in-kind sponsor for this podcast. Okay, the learner objectives. So what you're going to learn here, number one, list 3 questions to ask after a frenectomy has been deemed to have failed. Number 2, be able to list 3 professionals that should be involved in the tongue tie cases for collaborative care. And number 3, list 3 factors that contribute to poor frenectomy outcomes. Okay, let's get started. Autumn, my first question to dig in here is, how often would you say that you do encounter a client that you think they possibly had a failed frenectomy?
That's so hard to say. I would say it was a high percentage earlier in my career. Yeah, much higher percentage earlier. As practice evolves, we learn a lot of things. Research coming out and, just from your cases as well. Back then, so I've been doing this for 15 years. I've been in the tongue tie world for 15 years. So it's been kind of cool to see things progress and evolve. A lot of the reasons that we didn't get good outcomes was that providers were doing procedures without there being a functional evaluation and a team on board. So I definitely saw it a lot more often back then. I still do see it, and it happens under two circumstances at this point. It happens if a patient decides to go and do it without like us recommending it, or saying that they're prepared to do it, or they go to somebody that isn't really trained or specialized in it. And then the other avenue is, those are the two avenues. If they just go, and if they don't see somebody really truly specialized in it.
I see. Yeah. So you've probably built quite a team where as it's up to you, you probably eliminate, at least decrease all the chances that you can of it not working out. So
yes,
that makes sense that it was earlier in your career. If someone moves to your area and, didn't get the great team that you already kind of have in place.
Yep. Took a while to build it, but yes. So all our providers that we work with have specific training. They play well in the sandbox with us. They know the value of having, therapy on board, and they don't do releases without, specific referrals and kind of the green light, if you will. So yeah. Definitely decreased.
Okay. That's really cool. I have taken your TOTS course, and it was amazing.
Thanks.
And I am kind of I'm trying to get into that niche, so I'm trying to find my people in my area that can be a part of my team, and that we all have the same vision and values when it comes to TOTS. I know that there can be some different viewpoints sometimes. So that can be a little bit of a challenge, but we will get into that a little bit more on the other professionals. Let's see. So what is it that you see? So when you do see a frenectomy that you are like, ooh, or you see a kid and how they're functioning and what's going on, and you're questioning if maybe they did have a failed frenectomy, explain to us a little bit what you're seeing. What makes those red flags go off for you?
Yeah. So, I mean, honestly, it's usually more questions than answers at first. And so digging into that, say a patient had a frenectomy prior to seeing us or whatnot. I just gather as much information as possible. So obviously the diagnostics, they're going to have functional issues that we're seeing. They're going to have poor range of motion measurements. They're going to score poorly on the tongue tie assessment tools and things like that. But I'm going to dive in and ask a lot of questions. I'm going to ask like, okay, who did you see? What type of procedure was it? Was it laser? If so, what type? Was it scissors? Was it electrocautery? All of these different tools make a difference with how it heals. And then, also, was there stitches put in, or was it left open? Did you have therapy and evaluation before? What about after? So all of those things, play a role. Was an evaluation done? Was this actually needed? Because, if a release is done unnecessarily, it can definitely heal or reattach tighter than it was in the first place. So lots of questions to ask. A big question that I get often is people ask, well, is it reattachment, or is it incomplete, or is it poor healing? And so differentiating those is sometimes tough. And I am reluctant to say, like, if I didn't see it right after, I'm not going to say it was an incomplete or poor release, because I don't know, right? It's been said and done. But you can kind of ascertain if it was reattachment, because if you ask, what improvement did you see? If they say there was improvement and then we trailed off, then that's usually a sign that it was probably a good release, but we had some reattachment going. It's hard to define reattachment, right? I think it definitely comes with practice. And reattachment is where that diamond just kind of folds in on itself and sticks to itself. and heals that way instead of, this way. Whereas tight healing is under the surface and has to do with the fascia and the muscle and how they remodel and heal. And there's a lot of things that impact healing. And that's the thing, is it's so hard to capture all those variables and account for all of them. So yeah, if there's a potential failed release that I'm suspecting, I'm going to be asking a lot of questions to kind of figure out what happened. And if there is a need for another release, we're going to do something different, right? So doing the same thing over and over again doesn't have good outcomes. We're going to try and figure out what didn't go ideal and try to mitigate that.
Okay, that makes sense. So before we're going to get into those questions and your top 3 questions a little bit, even more here in a moment. But before we do, let's paint a pretty basic overview of the timeline of a frenectomy, just so that those that haven't taken your course or don't really know much about it just yet know kind of what the steps are leading up to it. Because as we know, it is not a one day, you have a frenectomy, snip, you're done. Right. There's more to it. Just a basic overview of the timeline.
Absolutely. Yeah. And, this is kind of the linear steps. Some, as far as time frame, there's not always like, 5 sessions before, 5 sessions after. It depends on how they progress. And one of the misnomers that I think, is still happening is people do an evaluation and then they just do therapy afterward. And so I created something called therapeutic readiness, and it was basically factors that I saw frequent patterns recurring in my practice of like, what patients had better outcomes? What did we achieve prior to that procedure to help that outcome and seeing those practice patterns? But in general, evaluation by the functional professionals. So, we have mainly probably speech pathologists on here. So whether you're working on feeding or myofunctional therapy or articulation, that's your role, is to do that whole global evaluation and integrate a tongue tie assessment into your full evaluation. So for the sake of this example, we're going to say, clinical indicators point to a tongue tie. You're not going to directly go straight to a procedure. You want to get, rapport built. You want to see how they do with conservative therapy, right? Because if they don't need it and things have improved and they're functional, then why have a procedure? So you want to give it that chance and do some therapy before, and hopefully get to that benchmark, that therapeutic readiness benchmark. I recommend body work prior to the procedure as well, just to help align things, reduce tension, calm the nervous system. All of those things influence procedure and healing, right? So therapy, get that readiness, some body work, and that could be chiropractic, that could be craniosacral, that could be myofascial release, like whatever. Yeah. And then the surgery happens, and then therapy and body work on the back end, to retrain patterns, get that function so that they're not plagued by the symptoms. So that's kind of like the timeline or order of operations there.
Yes. Okay. Thank you. I think that paints a good picture for those that just need to kind of hear like the bigger picture, and then we're going to dive in. Okay. So say I do have a client that comes into my office and the parent tells me they previously or as an infant had a tongue tie. What questions? And so these are our, put a little star. This is one of our learner objectives. What question should we ask the client or parent to learn more about the previous procedure or therapy? I know you rattled off a ton, so let's tackle maybe top 3 one at a time here, and really dig into each one.
Okay. So number 1, I want to know if it was necessary. Was there an evaluation done that deemed that function was affected by this structure? So was it needed, number 1? Because if it wasn't and they're still having problems, when tongue tie wasn't the problem in the first place, you know? So if they did not have an evaluation, you know, you kind of can take that procedure with a grain of salt. And I also ask, like, what did you try? What were the issues you were experiencing and what did you try? And yeah. Was there improvement? So, okay. Say they had a release as a baby, like you said. Okay. Did you see a lactation consultant? Did someone support you, you know, with milk supply and latching and all of those things? Was there improvement with those interventions? Was there improvement after the tongue tie release? Because if not, then it's potentially either an incomplete release or that wasn't the problem in the first place. And then if they did say they got improvement but then it kind of faded out, that's probably a reattachment, but it's hard to say when you see them months to years later, right?
Right.
So those are 2 questions that I would ask. A third question, just narrowing it down. You know, what type of procedure was it? Was it done with laser, scissors? Were there stitches put in? Those all affect healing. And, you know, if the wound was left open, did they give you anything to do after to make sure we directed the healing? So those can kind of come into play when, you know, thinking about the success or non-success of a procedure. And, you know, it goes hand in hand. Like the functional side has to work with the structural surgery and vice versa. So one or the other in the case of a tongue tie doesn't fix it, right? They have to marry together.
Right. Okay. So let's see. I have a few questions about each of those. So the whether or not it's needed, do you think that this was typically a rushed procedure or they just truly thought it might have been a tongue tie or a tie and it wasn't? What do you think really happens there? Why does that happen?
I think it could be a few things. I think therapists, number 1, most therapists are not educated on this, right? I know I wasn't very minimal in school, and we have such a wide scope of practice. So many therapists are not educated on it in the first place. And so, you know, they haven't been taught how to do an assessment and what symptoms tongue ties cause and how to ascertain that. So I think that is definitely an issue. And then I think the other issue is like ENT and dentists, the same thing, right? And they're looking at the structure. They're not looking at the function. Like they're not a lactation consultant. They can't say, oh, the breastfeeding's good or not good, right? You can't learn everything. And that's why this collaborative approach is really just absolutely crucial and necessary. So yes, I do think sometimes it can be rushed, especially like if release providers just take someone off the street, right? I think my baby has a lip tie. Please help me. And they want to be helpful, but what they haven't realized sometimes is that it's actually harmful. If the patient wasn't ready, if the family wasn't ready, right? We don't only prep the patient, but we prep the family. If, you know, they don't have that therapy to get correct function, you can do the most beautiful procedure in the world, but, you know, if that isn't in place, you're probably not going to get a great outcome. And so it comes from like, you know, people want to help. And also, I think parents and patients often tend to think, well, the problem's a tongue tie, let's cut the tongue tie, which I get that. But, I don't know why it's treated different than, a shoulder surgery, So that physical therapy piece is critical to the repair of the ligament or whatnot. So I do think sometimes it's rushed, and I do think it is a lack of education, which is part of my mission. Yeah, I think both of those things.
Okay. Yeah, that makes a lot of sense. With the improvement, I'm trying to picture kind of a bell curve. Like what's the timeline on that? Do you feel like, I guess it probably depends on the age. If it's an infant trying to nurse, how long might they improve? And like, what do you look for? Is it just like a few days they're better and then it heals up kind of quickly, or
really good question?
Months?
So it's gonna depend a lot on their healing factors and how quickly they heal. Generally speaking, I know you learned this in TOTS, but we have those 3 phases of healing. And the second phase of healing is the phase that we can get reattachment. And so that time frame, I think it's day 8 to 21, is typically the like caution phase, right? So, but of course there are patients that heal faster and patients that heal slower. So just kind of watching, there's markers of wound healing, right? Like how open it is, how much granulation tissue, the color of the wound, those sort of things that can give you the tracking of what phase of healing we're in. So it's during that second phase of healing that you can really be cautious of reattachment. As far as like the improvement and then the slope down, yeah, that depends a lot. But essentially, if over time, over that first week to 2 weeks, we're slowly tracking up, right? So for example, I had a little, I think she was like 7 months, and she wasn't eating a lot of solids. And after her procedure, I mean, the first couple days, you're sore, I kind of put that out the window as far as data. Now, some just like click right in. And I definitely think that therapeutic readiness helps it kind of snap in. But first few days, sore, not doing a lot. But then we start tracking upward as far as like her volume that she was eating. And then I think it was probably 14 to 15 days. There was a skipped point. I didn't get to see her because she was sick. And that's when we started tracking down. And so at first we thought like, oh, okay, ear infection. She doesn't feel good. Maybe she's not eating more, like whatever. But then when I saw her and saw the tissue and felt and all of that, it was a reattachment, and we stopped progressing and actually even regressed. The thing is, when you open up that tissue, you're opening up surface area. And when you're opening up surface area, it can fold in even more so and more attached than it was. So yeah, seeing a regression in that second phase of wound healing timeline is typically my red flag.
Okay, the second phase, and you said that's day 8 through, typically 8 through
to 21.
8 to 21.
Yeah.
So like after a week to like 3 weeks. Okay.
Yep.
Okay, that's good to kind of keep your eye on that. That's interesting. Okay, then my next one about the last one, what type? I know this could probably be a whole nother episode, but so I know there are different types. There's the laser, there's the scalpel. Do you prefer one, or is there one that has better outcomes? I know you did talk about this and taught some, but I thought this would be a good question.
Yeah, it is a great question. And that's like the age-old question. Which is better? What do I go for? Well, here's the thing. What's better for one patient is not better for another patient. And so it comes down to the training and the skill of the provider using it. and knowing the properties of it and how it helps, how it affects wound healing, right? There are considerations and advantages for each type. So one thing that is research-based is that with scissors or scalpel, basically cold steel, you have higher inflammation levels. Like, that is solid research-based. There is also research, we talked about this, in difference in pain level and difficulty with chewing and talking after the procedure. And they compared patients that did a CO2 laser versus patients that did scissors. And the pain rating was much higher in the scissors at, I think they did day 1 and day 7. So there's something to be said for that, because I could go deep into this, deep dive into this. But here's the point. It depends on who the provider is. I would trust an amazing provider with a paperclip. Like, that's what it kind of comes down to. And, we're blessed. I've built this community, and I went from one provider that only did infants when I first moved here in 2014 to now we have 8 that do, everything in between, adults, toddlers, teenagers, whatnot. And so it's great because we have different options. We have sedation or awake. We have scissors. We have diode. We have CO2 laser. Location, insurance, personality, all of those things. We have all these choices to match with what a patient would be best for and needs. Stitches, no stitches. So yeah, really important, especially when we talk about procedure, it's case selection. And so, if you have a child with significant sensory issues, or it's going to be traumatic to do some of that aftercare and managing the wound. And they come to me and they're like, oh, we already had a tongue tie release and it was a disaster. Well, we're definitely going to probably be pursuing sedation and stitches, right? So that probably wasn't the appropriate type of tongue tie release for that specific child. Now, that can work beautifully for another patient. So yeah, it really is case specific, and lots of questions you have to ask yourself. And, gathering the providers that offer all these different options takes a good bit of time and effort for sure.
That's a lot to think about, because it's not just, there's not one right answer, right? It's depending on each individual and what they need. So,
and that always happens. We're dealing with individuals and, people with different dynamics and factors and whatnot. And it annoys me to say this, but like, when people ask something, I'm like, it depends, because there isn't a black and white. Like, when you're dealing with people and unique humans, there just isn't. And so having that arsenal of questions to ask them, ask yourself, to make decisions based on their specific info is really where we need to be.
Right. Yeah. So now getting into, you just mentioned how important it is to have a team and how you've developed a pretty awesome team in your area. I wish every area had little Autumns everywhere, but if someone's trying to, gather up all the professionals to have a really great team, who are the top 3 professionals that you want on board?
Yeah. So this is like what I call the core team. These are the 3 that are like, absolutely every tongue tie case needs these 3, right? And then we have peripheral professionals that may be involved. It depends on the case, right? So the main 3, the core 3, is the oral function professional. So the person working on feeding and swallowing, working on speech, working on tongue rest posture, or myofunctional type therapy. So that's the oral function professional. And that, obviously we're talking to SLPs here, but that could be an OT doing feeding, or a PT doing myofunctional therapy, or a dental hygienist doing myofunctional therapy, or a lactation consultant, working with babies breastfeeding. So that oral function can encompass different professions suitable for the age and the issue. So that's number one. Body worker. So I mentioned why that's important: reducing inflammation, reducing discomfort, aligning everything, calming the nervous system. So again, that can be a variety of people. Body work is kind of an umbrella, and that could be a PT and OT doing manual therapy, craniosacral therapist, an osteopath, chiropractor, a massage therapist. That could be a variety of people, right? So it's really comes down to, who's trained and what professionals, really want to understand this and specialize in this. So that really helps to integrate the whole body, because a tongue tie is never just a tongue tie, right? It affects through the fascial system, and relates to things like potentially toe walking, potentially forward head posture, breathing, paradoxical breathing, vocal tension dysphonia, that sort of stuff. So integrating the whole body and not just working in one spot. And then the third core team member is that release provider. So the person doing the procedure or surgery. And that can be variable too. That could be ENT, that could be pediatrician. It could be a nurse practitioner, a dentist. Yeah, whoever is trained and doing those in your area. So those are kind of the three, oral function, whole body, and structure, right?
Right.
So yeah, those are the core three.
Okay. So thinking of that last one, the provider, in my area, I found that there's a handful of pediatric dentists that are really aligned with what you have taught me in the courses I've taken. I just haven't yet found an ENT that in my area, and I did just move here, so there's probably some out there.
There's time.
Yeah, I just moved to New Braunfels from like Austin, so there's still time to find them. But I have, even in Austin, I kind of struggled to find an ENT that was a little more airway centric and just a little open to, I don't know, the way we view tongue ties and what's like needed. What do you do to find someone? I mean, besides going to all their websites and reading their About Me page and calling up there, do you meet with them? How do you form your team?
So this is something, if anyone needs help on this, I did create a little mini course on this where I deep dive into the whole thing. But my best hot tips for this is personal relationships. You're not going to convince somebody. No one likes research dropped off at their office. If I don't know you and you drop research off at my office, A, I'm not going to read it because I don't know you. And B, it's insulting. It makes you feel like they're telling you how to do their job and that you may not be up on the research. And that may be very true, but the perception of it is going to be off-putting. That is not going to work. I've never seen it work. Thankfully, I did not try that. But sending reports, they don't have time to read those. And I think the key is meeting them. And essentially, ENT, call up their practice manager, call up their personal nurse, whoever. Hey, I'm a speech pathologist. We have some mutual patients. I'd like to talk to Dr. So-and-so. Here's my personal cell. And I mean, if they don't call you back, that's probably not someone you want to work with anyway. So yeah, that's how I've gotten them on board. They call me back. I say, hey, like, I'd love to, pick your brain, make them feel important. Um, ask, and sit down. I like going to neutral places, not my office, not their office. I like just, hey, like, let's go down the street to the coffee shop. I have some questions about the cases that we're working with. And then, like, just telling them your philosophy and asking them theirs and asking them for help. Like, hey, I have patients that, really have tongue ties, but a lot of ENTs that, I've worked with, have stuck a tongue depressor in there straight on and decided if it was tight or not without considering all the things that I'm assessing. And, I utilize a validated assessment protocol and, whatnot. Could you, what do you know about that? Could you help me with that? I need someone to send my patients to help them. That's one way. Another way is to take one of your patients that has had great success and they're a patient of them too. All people usually need is one case that had outstanding results because that's real to them. That is a patient that comes in their office that trusts them for their health, that they can see the real change in them, right? And so that usually gets people listening and on board and whatnot. Yeah, and it's not a one time. It's an ongoing thing. And one of the things I really ask is, how do you prefer to be communicated with? Do you like email? Do you like fax? Do you like a text? Like what works for you? So yeah, it's definitely a challenge. And then once you have that relationship developed, you can dive a little deeper and you can say, oh, hey, I took this course and this is what I learned. Do you think we could try this? Or what do you think? Or, hey, I read this new study. I thought it was interesting. What do you think? Because they already are kind of friendly with you and you already have a relationship. So they don't perceive it as you telling them their inadequacies or that how they're trying to do their job. Yeah.
Okay. So you mentioned having a patient in common. How do you go about letting them know? Do you ask that family to mention that they are specifically seeing you, or it was just with HIPAA? How do you connect the dots?
Well, I mean, if they're seeing both of you and you have notes from them and they have notes from you, like that's all.
Okay, and the family has shared that, and it's
exactly. That's all shared. That's all fleshed out.
Okay,
but I do, because the paradigm's never going to change. If pediatricians, if dentists, if ENTs don't know the success of tongue ties, they are going to listen to the media. That it's a fad, that it's, a moneymaker, that it's whatever. So I do tell my patients, like if they've had, I hate to throw pediatricians under the bus, but it's the most common that I hear. If they had a provider, a pediatrician, or their regular family dentist or whatever say, oh, that's not a thing. They'll grow out of it. You don't need to do anything about it. And they go and get, do therapy and get their tie released and things are better. They need to communicate that back, right? It comes so nice from the patient. And like I said, that real human sitting in front of them versus, if I send them a report, they're not going to read it. And, that's all clinical mumbo jumbo, right? But if they hear someone saying, oh my gosh, my nipple pain is gone with nursing my baby, or Johnny was stalled out on his speech progress and kind of plateaued, and now we're super stimulable for all these sounds pretty soon following this release, or whatever it is going on.
Okay. Yeah. No, that's great. Okay. So we talked a lot about the team and everything, and that Frenectomies can fail. So what are those 3 factors that contribute to poor frenectomy outcomes? This is another one that we're having to list. So let's start with one of them.
All right. So those 3 poor healing factors.
Mm-hmm.
So anything that relates to high inflammation is a factor for poor healing. The body can't rest and digest and rebuild and heal when it's in that fight or flight inflammation period. And there's normal inflammation with a release, but when we're super high, like things like eating irritating foods, like sugary processed foods are highly inflammatory. Things like not being regulated sensory wise, right? That nervous system is on alert and inflamed, and we can't learn new things and movement patterns when that's happening. So therefore, they're likely not moving their tongue as much, and things are contracting down. Other things that contribute to inflammation, lots of different things, as far as like vitamin imbalances, hormonal imbalances, other systemic factors like diabetes or anything that influences wounds and healing and contributes to inflammation can be a factor. Yeah. And lots of diagnoses, like I mentioned, diabetes, connective tissue disorders, those sort of things can definitely influence. But a big one is inflammation. And one of the things that I see is people being very aggressive with the aftercare stretches, and it creates more and more inflammation. Or they're waking their child up multiple times a night. Well, sleep is the point where we heal. That's when we secrete growth hormone. You can't heal well if you're constantly sleep deprived. So, yeah, all of those things can affect, and yeah, there's numerous factors there.
Okay, awesome. I never thought about that, especially for, babies that are having formula or breast milk, but especially if it's an older kid, what they're eating, especially, if it's sugary foods or all that stuff. That's really interesting. Even vitamins, all the things.
And that's super hard, especially when we're seeing picky eaters, right? Ones that chicken nuggets.
They often might be, yeah.
That's really hard, right? Because they have to eat, like, obviously, but you can just know that, hey, there's going to be more inflammation going on. So therefore, potentially more discomfort and a higher likelihood of not great healing. So, yeah.
Okay. Do you help families work out kind of a diet plan if a kid's really picky, or are there certain foods that are really good? So maybe,
right.
I don't know, something cold, or that to me, I don't know, does that feel better?
I totally make recommendations. And things that you can go from, like, more natural versus processed, right? I talk to them about shopping the perimeter of the store. Or, if your kid eats goldfish, maybe you could do the Annie's bunnies, right? Less artificial ingredients and things like that. So little switches are great. Cold foods are fantastic, just reducing that inflammation and swelling. But ultimately, like, okay, if that's the only thing they're going to eat, then okay, gotta eat, right?
Right.
So there's like no judgment there. It's more of an education of, here's some swaps you can make that could potentially help.
Okay, that's helpful. Okay, so now that we've gone through all of that and we have a client, imaginary client here that has a failed frenectomy. How is it common to? You kind of touched on this, but let's go through more of like how to navigate it with the family. Is it common to try again or to go another route at that point?
Yeah, I think it depends on the answers to those questions we talked about. I am very judicious about recommending families investigate another procedure. But if it, Maybe it was because they didn't do aftercare or have therapy on board. Maybe it was just a highly stressful time in their life and they weren't mentally or emotionally ready. Maybe they didn't see someone trained. But obviously we're going to try therapy first. And if we're starting to hit like that plateau and no way around it, then that's when we're going to investigate again. I think our objectives were 3 poor healing outcomes. Is that right?
It was, yes.
Okay. I wanted to make sure I give the other 2.
Okay. So the other 2. Sorry.
I
got ahead
know.
of myself.
So
the first one was inflammation, and then you listed all the things about that could be
related to that.
Okay, and then number 2.
Yes. So the second one is not gaining that therapeutic readiness. So not having the preparation in place. So, if they have never activated certain tongue muscles and we don't teach them how to do that prior, now it's not going to move very far, right? Because we're tied, but we at least want to activate and create that mind muscle connection, right? And build and strengthen them as much as possible. Then you're going to move your tongue much easier. You're going to have a shorter treatment course because you've already learned how to use that muscle and now it's just freed up, right? Mm-hmm. So I found that really helps too, because if you just go and release, A, the tongue doesn't know what to do. B, it's not toned at all. So it's just kind of like a blob. And that can actually make things worse. And yeah, so definitely like getting that movement, getting that activation, getting some of that stability and stuff going really helps with better healing and shorter treatment course and things like that.
So with the tongue movements and things like that, if they aren't able, say it's a 5-year-old and they can't quite lift their tongue all the way up into their palate, maybe do you just try to get them as close as possible, or at least like try to get some of the tongue up, and then you just keep working, and then when you start to plateau, then that's where, okay.
And so, I would rather get the tongue flat on the roof of their mouth and them not open very much versus like really poor form and they're wide open. You know what I mean? Mm-hmm. So we want to work on activating the right muscles, or say the tie prevents them from fully lateralizing. Well, what's the harm in getting at least as far over as we can, right? Because you're building that muscle, even though the range of motion is impaired. So I found that definitely, it's just a bigger learning curve. And so things just get stagnant and really contract. And then the third one is difficulty with aftercare. So, when we're not separating that tissue and guiding that wound healing, natural wounds want to protect the body. They want to close. They want the body not to be vulnerable, and they just want to close, right? And so we've got to guide it so it heals in that elongated manner. And so difficulty, that can look like a lot of different things. That can look like just not doing it, right? But usually there's a reason they're not doing it, right? It might be that it's too stressful. It might be that they don't have time and like their life is chaos. It might be that, it's more traumatic to the child. It might be that the parent doesn't really feel prepared and know what they're doing to do these aftercare lifts, right? And so that's where that pre-therapy really helps, is preparing all of that. And also that case selection of, I tend to have my patients try it. Like, okay, they're saying, we don't want sedation, we don't want stitches. In my head, I'm like, you're going to need them. But I let them kind of figure that out. I'm like, okay, well, here's what you would need to do. Go home and try this for a week. And, 9 times out of 10, they come back and they're like, oh my gosh, this is not doable for this specific case, right? And then they're making their decision. Other times, like, it kind of surprises me, and we do a lot of like role playing. We do a lot of games and positive reinforcement, and, the patient's working on me and I work on their parent, and just to demonstrate so that we can kind of ascertain what the best type of procedure would be for them. In the case of a reattachment, I almost always opt for sutures because it's less that you're leaving up to chance.
Okay. Yeah, that sounds like a great idea to have them practice it and stuff, because goodness, yeah, that would be a lot, post frenectomy, and then, there could be pain. Then if your child is not having it, not having you anywhere near their mouth, not, it's probably, scary for them or whatever. Having a good routine or practicing it ahead of time can make a huge difference. I can see that.
Definitely. And, the parent feels empowered and more, they know the position, they know the pressure to use, they know the placement, so that, it's not totally new.
Right. The parent isn't as scared too going in. They feel confident or more confident and able to do it. That makes a lot of sense.
Yep.
Okay. Awesome. Well, I think we're about ready for our Q&A portion.
Yeah.
Unless you had any other thoughts, but there'll be lots of few questions here. And if you are live, go ahead and type in some questions into the chat, and I'll look at those. And then we also have some questions here written out. I'll make sure the chat is open. We'll start off. I actually have a question. My daughter had a posterior tongue tie and a lip tie released at about 1 month old. She's now 7 and needed an expander. She just got her expander like 2 weeks ago, so that's kind of new. She also mouth breathes at night, deals with chronic congestion, has an open bite, and kind of has all those same symptoms. She originally got the release. We really struggled breastfeeding. It was a horrible situation, and then it got a lot better, and we were able to breastfeed till 10 months, which I feel like was a great accomplishment for me and what was going on in our life and what I wanted. But I'm just with even my own experience, I am so confused. What went wrong? Why does she still have all this going on?
Yeah.
I guess in her mouth.
That's a good question. So many times we get the skills for breastfeeding under control, but the movements we need for the rest of our life don't just come into place. And part of that is because we're born with a tongue tie, right? And that's been there since in utero. And so sometimes the development progression doesn't get there. So great, she's cupping her tongue, she's swallowing, she can handle the flow, she can latch on deeper, you're out of pain or whatever were your symptoms, right?
Mm-hmm.
But when we get to other things like resting your tongue up, right, that may not just fall into place. And so that's something that I'm definitely teaching a lot of lactation consultants, and they're learning that it's not only about breastfeeding, it's about the airway, it's about future things, right? Mm-hmm. So I like to say there's epigenetics, right? Like breastfeeding, eating, whole foods and less processed foods, because that's like building the jaw, not having thumb sucking or prolonged pacifier use, utilizing a cup or a straw versus like a sippy cup, all of those things, right? And then there's just good old genetics. So it's both. Yeah, and I'm sure you can like look back and think about it, like, did she have an airway obstruction and that's why we've had our mouth open? was our tongue just not resting up? Just because it's released doesn't mean it floats up, right?
Mhm.
And so now we're narrow and need that expander. So yeah, could be a variety of things, but it's not like super uncommon to see that. And, there are some studies that show like children released as infants have a higher likelihood of speech issues than those that never had a tongue tie in first place. So there is always that factor that that history is what I'm trying to say. So
Okay.
yeah,
So it was already kind of genetically a potential.
predisposed. Yeah,
Yeah.
for sure. And then, looking at your family, tongue ties do run in families. So like, did anyone else snore and have teeth extractions or TMJ or expanders or all of that stuff? So from what I understand, jaw is 70% epigenetic and about 30% genetic. And so there's you control what you can control. But
Right.
yeah. Does she rest her tongue between her teeth, or are we a thumb user? Or
She doesn't. She did have a pacifier till a little bit too close to 2. Should have done that earlier, but first child, you're surviving. I don't think she with her S's, it was getting better, but whenever she lost her 2 big front teeth, then she formed a little bit more of a frontal lisp.
yeah.
So maybe it just she was already doing it some, and then maybe just she was like, oh, more space.
Yeah, right. Right. We don't
and then
have
it formed that open bite. It was after she lost her front teeth. They really kind of didn't really grow down until she got her expander, because she kept, I guess,
narrow and having that tongue.
It's potentially she has a tongue thrust swallow too. I need to dig into that a little bit.
I would guess if we have that saying, fix the swallow, the speech will follow. Where you rest is where you rest. So, probably low tongue rest posture and
yes.
Yep. And definitely those teeth not being there. This is kind of a misnomer. A lot of people think, oh, that's why they're thrusting. And yes, if they were up against their teeth in the first place, and now that's not there, then yes, they're going forward. But they shouldn't be against their teeth for S. So that shouldn't affect it, right? In theory, if it was correct in the first place.
I think she was already doing, and then it was just more
exacerbated it.
Yeah, you could see it a little. It was more obvious. Right. Yeah. Okay. Well, that's helpful, and especially, other people might have that question if that's a common thing. If a lot of kids that did have a tongue tie and then now they're dealing with XYZ different issues. So okay.
Yeah, for sure.
My next question is: can a tongue tie hinder a child's speech sound development, or SH, CH, L, etc., delay generalization? I know that could be a big answer, but just even in general, I feel like that's a hot topic.
It is.
What do you think?
Yeah, overall, number 1, yes, because I've seen it. Number 2, speech is like the most rapid millisecond, fine motor activity, right? Like they are very precise, rapid movements. And when the tongue is struggling and pulling against resistance, it can't change shape and tense and move as rapidly as speech requires. So the generalization piece is something huge. I see often the child can say the sound in isolation, say the sound in single words. We even get short sentences, but oh my gosh, in conversation, it falls apart. And it's just like if your shoes were tied together. Okay, that's limited range of motion. Can you walk? Yep, baby steps. But if you try to run, you're going to fall apart, right? So, I feel like they can compensate, but only so far. And when you get to that higher level where it's just expected to move, and these children also have really poor diadochokinesis. Like if you're doing the whole Pudica, peanut butter cup. Yeah, that too. Language development. So here's the thing. I think it can, but not in the general sense of what we're thinking. So I've seen kids that are labeled as an expressive language delay. And yes, because they're not saying words or, communicating, right? But if they don't have the capacity to move one of their major articulators, they may receptively understand and know what words they want to say and have meaning behind them, but not be able to form it. And so as language itself, no. As the output of the language, potentially, yeah. And it's hard to say because is it maturation? Is it tongue tie? Is it because of therapy? Is it just the language burst that happens? Like, yeah. What's the reason? But, honestly, like if there's a tongue tie and we are expressive language delay, and we have other things going on, mouth breathing, low oral tone, like all of that stuff, that's going to like paint a picture. And, even things like CP or some other medical diagnosis, it's not going to fix everything. But it is one barrier to their success that fortunately we have a treatment for.
Awesome. Yeah. I've definitely seen that in kids too. Even recently, now that have my eye on that a little bit more after taking some courses and stuff. And so that's interesting. That is kind of a hot topic, but it seems like very clearly that, your tongue does need to move in these very precise movements, way more precise than other muscles.
That's what I say. Yeah. Like, it's just it's sort of common sense to me. Like, yeah, it's just, it's a lot of semantics and turf wars and yeah.
Yeah. Yes, I totally agree. Okay, so I think we're going to stop the questions here. I didn't see any more in the chat, but you guys, if you want to learn more about Autumn, make sure that you are following her on Instagram at chrysalisoralfacial1, and her website is chrysalisoralfacial.com. Now that you have listened to the entire course, click on the link in the show notes to get CE credit. There's a small processing fee, quiz, and then you download your certificate. Message to my live audience in the link in the chat. Here, let me make sure I have the link in the chat for you guys. You can grab that right now, or if you registered, you will get an email with it as well. So or you could go to my website, Pep Talk Podcast for SLPs.com, and go to courses. This is course number 27, Successful Tongue Tie Releases and Why Some Fail. So thank you so much for being here, Autumn, and everyone in my virtual live studio audience. And thank you once again, Spot Pal, for sponsoring this episode. I'm going to play their wonderful video one more time for you guys. And
your tongue should rest in a nice suction to the roof of your mouth to eliminate any type of tongue thrusting habit or to eliminate any type of sucking habit. Spot Pal is a custom fit tongue training appliance. It is designed to teach proper tongue posture and get the tongue to fit up within the confines of the palate where your tongue should naturally rest.
Speech Pal is our speech therapy version that is designed with the additional feature of the speech bumps on the inside of the upper molars, and these give tactile cues for the user, especially for the R sound. So with the spot dot and the speech bumps, we can target the S, Z, L, R, SH, CH, the J, the J, the T, D, and N sounds with tactile cues for the tongue.
Awesome. All right. Well, thanks, Autumn, so much. I love chatting with you.
Thank you for having me.
All right. Bye, guys.